Welcome to today's infectious disease echo. Today is June 9th, 2023. If you will go ahead and enter your name into the chat along with your organization and your position so we can take attendance. Today we have two presentations. We have Anna Garrett doing the epi updates for COVID and influenza for the area, for the USET area. And then we have Dr. Merritt doing a presentation on Lyme disease. And he's going to tackle other tick-borne illnesses as well. And yeah, I think that's it. So Anna, if you want to go ahead and get started.
All right, perfect. Let me just share my screen here. All right, and you can see that all okay, just making sure. Perfect. All right, so we'll go ahead, jump right in to our COVID-19 update. I do just want to let everyone know this is going to be the last COVID-19 epi update and the last flu epi update on the infectious disease echo. We just sent out our last COVID-19 report, the aggregate and the tribal nation specific one at the beginning of the month. And then we also did send out our last biweekly influenza surveillance report as well at the beginning of the month. So again, we have the same data sources we have been using. After we go through this, there is a little bit of an update for the COVID-19 community levels that we'll get into. But for this last report, we were able to kind of get that last round of the COVID-19 community levels. So as we can see from the beginning of May compared to the very end of May, so 5/30 of 2023 was when the last COVID surveillance report was issued. So that is standing in for the June one. We have similar variants as before. We have a decrease in the total number of patients hospitalized with COVID-19 within the USET PERCTA, as well as the USET states. Both of those have decreased a little bit. The total number of COVID-19 positive tests at the IHS Nashville area last week was 9 compared to 23 at the beginning of the month. And then our 7-day positivity rate is down to 2.7% compared to about a month ago at 6.7%. So COVID is definitely trending downward here, which is good. Just quickly going over the variants of concern, it's mainly this XBB variant that we have been talking about. So that's in this kind of purplish color here. We're seeing the same trend across the whole United States, as well as this USET region here with XBB as that primary variant. For the COVID-19 community levels within the USET states, we see here we're primarily in this low level for the beginning of May. Compared to the end of May, we have them all in this low level except for a few counties in Texas. So no changes there that are too surprising. For the COVID-19 community levels, they have actually gone away. They're replaced with the COVID-19 hospital admissions level. Just due to the end of the public health emergency, there have been a lot of changes kind of in the surveillance and data collection going on for COVID. So I'm briefly just going to touch on them, but I can put the links in the chat if you are using any of these kind of data sources or methods to do any internal reports or surveillance. So again, the COVID-19 hospital admissions level, they're kind of following the same, low, medium, high as the community level, but they're not an aggregate of the metrics like that community level was. So again, just when the levels are, low, medium, or high, just recommending staying up to date on vaccinations, ventilation, avoiding contact with people who are suspected or have COVID, and then following any isolation or exposure guidelines. Again, when the hospital admissions level get into medium or even high, just making sure to wear a high quality mask, and then just being cautious if you are at a higher risk. And then community level prevention strategies, you can kind of read them here, but low, medium, and high, just making sure everyone has equitable access, to vaccination, testing, masks, respirators, treatment, community outreach and support, which is always our main goal. Again, considering ventilations, making sure everyone has testing available, and then just again, continuing on with that communication and messaging to encourage those who are positive, just, to remain in isolation. If the levels do get to medium or high, they're recommending screening testing. And then if they are high, just considering that healthcare surge support based on your own clinic. This is a chart of all the changes to the national COVID-19 surveillance kind of metrics that have been going on. We see 3 down at the bottom here have been discontinued as of May 11th. Some of these are changed, but they are still going to be continued to be reported. And again, I'll send the link to that if these are any metrics you are using. These are the same metrics with just a little bit more detail on exactly what that metric is, the surveillance data source, and then what geographic level that the numbers will be reported at. Moving on to the COVID-19 national wastewater surveillance, we're seeing a lot of these percentage of wastewater samples do have SARS-CoV-2 in them, which is not, super surprising. For the COVID-19 hospital admissions, we have again seen that slight decrease from 46 down to about 40 for the USET PERCTA. For the USET states, we were at 277, and now we've decreased to 224. And then overall in the United States, from about 958, we've decreased to about 774. So those are all decreasing, which is good. The percentage of total inpatient hospital beds used, we're kind of staying, relatively similar for the United States and the USET PERCTA here in the gray, and then that yellow line just directly under that. For the USET states, we are just trending downward a little bit, but, relatively remaining somewhat consistent. No big spikes or dips there. For the COVID-19 vaccination data, again, we're staying relatively similar, just some slight increases with the population fully vaccinated. So those, with that primary booster series. Again, these are the different states within the USET region compared to the reporting facilities within the IHS Nashville area. All of these are remaining relatively consistent with some slight increases in the changing of the month, but nothing too surprising there, or no large changes. Again, for that bivalent booster dose, again, everything remaining relatively consistent with just some slight increases in that vaccination rate. Again, the data sources are linked here. Again, the COVID-19 community levels are no longer existing, but they were linked there. That page is now replaced by the hospital admission levels. For influenza, the data sources are here. Just the general information, it was a biweekly report based on the morbidity and mortality weekly report, which is just the week of the epi year. So January 1st would be week 1, and so on. Again, influenza-like illness is a respiratory illness, including fever and a cough or sore throat, but is not necessarily laboratory confirmed. So for the USET area, we are having everything remain relatively consistent here with our metrics. The percentage of influenza positive tests reported to CDC remaining at about 1.1% with just a slight less than 1% increase. The weighted percentage of visits for ILI reported to ILI net is remaining at about 2%, and that remained consistent from the week prior. The number of new influenza hospital admissions has decreased slightly by about 45. So now at MMWR week 20, which was May 14th, that week that's around 939. For the percentage of ILI visits for IHS nationwide, we're sitting at about 0.8%, which is a slight decrease from the week before. And then the percentage of ILI visits for the IHS Nashville area is sitting at about 1.3%, which is just a 0.1% increase from the week prior. For the ILI activity levels, which is this top map here, we're seeing most of the states are in, these minimal to low levels, which is good. And again, 2022 to 2023 season is this black line with the red triangles. Right now, we're sitting below this 2022-2023 national baseline, which is just this black dotted line here. So again, we have kind of seen our peak influenza season, and now we are just trending downwards beneath that baseline. For our vaccination rates for the IHS region over here on the left-hand side, we see nationally we're at about 31.7%. Nashville is slightly higher than that at 33.9% vaccinated who have had one dose of the seasonal influenza vaccine. On the right here by age group, we see our seniors, which is those 65 years and older, are about at 59%. And then we have our adults, which is 18 to 64 years, about 36.2%. And then children 6 months to 17 years is at 27.9%. And that hasn't changed too much from, the previous weeks, just some slight increases. The number of new hospital admissions by HHS Protect region. Again, everything has kind of leveled off here within the total United States and then within all of the regions that we have member tribal nations within. Again, if you have questions, feel free to ask them or reach out to us. If you do have any feedback about either the influenza or the COVID-19 report, feel free to let us know. We are considering a fall respiratory report, combining some different, respiratory illnesses for the fall. So please let us know any feedback that you may have.
Thank you, Anna. While I will miss your updates every month, I'm glad we are moving forward definitely with this. So does anybody have any questions for Anna? Hearing none, we can go ahead and move on to Dr. Mara's presentation on Lyme disease.
Okay, thank you. Can you see it correctly, or do I need to swap?
Yep, you're good.
Okay. Okay, and I'm going to be talking basically about Lyme disease. If there are questions about other tick-borne illnesses, I can cover them, or we can do this in a separate presentation because Lyme is a pretty broad topic in itself, and I tried to minimize it. My main disclosure is that I don't see a lot of Lyme disease. In Oklahoma is it's not one of the states in which Lyme disease is, you can acquire it, but you can import it if, someone has been into another state and got bitten by a black leg tick that was infected and caused the infection. So the objectives for this presentation is to describe the clinical presentation of Lyme, geographic distribution, vector in the United States. I'm not going to be talking about Lyme in Europe. Define the laboratory diagnosis of Lyme disease, which is sometimes the most confusing part about how to interpret the tests, and understands the importance of early recognition and treatment of Lyme disease. And I will be talking a little bit, quite a bit about ticks. I just make sure everybody has an understanding how the inoculation of the Borrelia happens, and some things that are important to know that have some clinical impact. And then clinical presentation of Lyme treatment, and just one quick mention on prevention. So we'll start with a question that you don't have to answer, but just keep it in mind and we'll answer it at the end. So which of the following statement is true? Ticks choose environment over host to survive. Ticks do not need pathogens to survive. Pathogens are transmitted from ticks to host through the tick's saliva. And most pathogens, when I'm talking about pathogens, I'm talking in this case of Borrelia, but it could be any other tick-borne illness, a pathogen. Most pathogens live in the tick's gut. All of them are correct, or only A and C are correct, meaning that tick choose the environment, not the host, and that the pathogens are transmitted by saliva from the tick to the host. So a couple of basic things about ticks. These are arthropods. They're more related to spiders and horse crabs than to insects. They are hematophagous, meaning they need blood to survive. Most tick disease are not inherited. What I'm talking about is not human inheritance, but tick inheritance. But there are some ticks that are infected with a pathogen can transmit the pathogen to their eggs. And when they lay those eggs are already infected. And when they hatch, the larvae are already infected with the pathogen. Most of the infections are peridomestic, meaning most of the people acquire the tick-borne illnesses around their homes, either because they have animals that are infested with ticks, like dogs, or because they have the right garden or plants in which ticks tend to live and attach to the human host when they're walking by that plant in particular, the brush. So the other important thing is that one tick can transmit several diseases, but they rarely do it at the same time. Usually it's a sequential infection, but you can have patients who get bitten by a tick, like a blackleg tick, and get babesia, and also get Lyme disease in the same inoculation, but that's not very frequent. Ticks choose the environment. So, I'll give you a little bit more hint about why this in the next few slides. So, but if humans change the environment or enter their environments, then the disease prevalence changes. And although I don't have slides on this topic, but due to climate change, the ticks are changing their distribution in the United States and in many other countries too. So we may be seeing in the future, tick-borne illnesses in areas, geographic areas, which they are not present or were not present in the past. And pathogens can only infect ticks in which their gut environment is favorable. So the pathogens go to the gut of the tick, and the tick tries to fight them off. And many times, sometimes they can do that, but for the pathogen to survive, it has to create certain proteins that cover the pathogen and prevent the tick microbiome from eliminating that particular pathogen. So as we mentioned, there are hematophagous vectors. They're not the reservoir of the infections. There usually needs to be a mammal, which is either deers or sometimes small rodents or other mammals. There are over 900 species of ticks described worldwide, but there's only 9 tick species that transmit infections in the United States, and only 2 tick species in the US that transmit Lyme disease. They have a defined and at the same time dynamic geographical distribution. I mean, they're defined today, but this may change in the future if the environments change and ticks migrate or search for other places. They have 3 basic life stages that I'll show you in a few. And a host can be any vertebrate. Different ticks stages have different hosts. So the tick goes from larva to nymph to adult, and each stage may have a predilection for a different host or a different animal to infect, to feed from. Each species of tick harbors specific pathogens. So although you may see that there are ticks in your area, just the fact that you have a tick does not mean that you're going to have a pathogen in that tick. So here's a cartoon of the different stages, the larva, nymph, then the adult female and male. This is just to show you the size of the ticks. And I'm sure most of you have gotten exposed to ticks in your life and you know what the size of them are. But the tricky ones are the small ones because you can't see them very easily. You may not be able to pull them out and prevent an infection. And these are just the 3 very common ticks in the US. The black leg tick, which is responsible for Lyme disease. The Lone Star tick, more in the southern United States, responsible, among other things, for ehrlichiosis. And the American dog tick, which is responsible for Rocky Mountain spotted fever. And here you can see a photograph of an engorged tick. That's a tick that's very happy, had a blood meal. And it is important to recognize them because if you are bitten by a tick and you pull out an engorged tick, that means that that tick could have transmitted an infection to you. If the tick is not if that particular tick is not engorged, that means that an infection is unlikely. So the ticks lay their eggs. These legs hatch into larvae, and the larva needs one blood meal. And all the purpose of its existence is to try to catch a host that walks by them, attached to the host, and get that blood meal. Once they have that blood meal, they will move into the next stage, which is a nymph, and then this one will move into the next stage, which is an adult tick. At each of these stages, they can transmit infections. And like I mentioned, the smaller ones are the dangerous ones because you don't see them as easy as you can spot them in your skin if they're large adult ticks. So do ticks choose host or environments? And the answer is that they choose the environment. It's not that they'll try to go to this place or this other geographic region because there's cows or there's deer or there's rabbits or there's mice or whatever, because the ticks cannot jump or fly. So it's not that they can fly and hit a host or jump into a host. They need a specific, bushes or that they can attach to and then be close to a host. When the host passes by, they can just attach to it. And that's why they will pick areas in which those plants, that the vegetation and the climate is favorable for them to survive. So there's a lot of studies done on many ticks, but on many pathogens, but there's quite a bit done on Borrelia burgdorferi, which is the main cause of Lyme disease in the United States, and Ixodes scapularis, which is the black leg tick. So when the tick bites the host and the host is infected, let's say it's a deer, the spirochetes rush to the feeding site. Okay, let me see. What I'm trying to say is that the tick bites you and it just not randomly picks up the spirochetes that are circulating in the blood at that time. The spirochetes sense through chemical sensors that there is a tick biting that host, and they go towards that tick to get inside the tick. And the tick salivary glands are the launching site for the next host. So they first go to the gut, and I'll show you some pictures of that. And then from the gut, they need to be activated, and then they go to the salivary glands, and that's when they can inject and infect a new host. The tick's immune system tries to get rid of the intruder, in this case, the Borrelia, but the Borrelia covers itself with certain proteins that it makes, and it prevents the tick immune system from killing that pathogen in their gut. And then when feeding times arrives, and I'll show you a better picture of that, the tick within the saliva can secrete a lot of substances, among them anti-complement chemical factors that facilitate the infection of the ticks, whatever's infecting the tick's gut, in this case Borrelia, to go into the human and not get eliminated quickly by complement levels, but innate immunity. So these are all the 9 ticks. I think I have them all here. Yep, that cause tick-borne illnesses in the United States, but these are the only 2 that cause Lyme disease. And that's the black-legged tick, or Oxytis scapularis, and the western black-legged tick, or the Oxytis pacificus. Actually, I put them on the wrong side, because tick you see on the right should be on the left, which affects that western part of the United States. And that in yellow in the map, you can see the range that the tick covers. Now, it's interesting, you can see the black-legged tick down to Texas. Now, you won't have Lyme disease occurring in Texas, because it not only depends on the tick, but it depends on the mammal host that can be infected by the Borrelia to carry it. So you need a lot of things to come together for this to happen. So the black-legged ticks, as I mentioned, not only can carry Borrelia, but they can carry Babesia, and they can carry Anaplasma, which causes anaplasmosis, human granulocytic anaplasmosis, which is another tick-borne illness. When you look at the map, the graph on the left, these are the reported tick-borne illnesses in the United States by year. You can see that in the green is Lyme, and Lyme is the most frequent tick-borne illness reported in the United States. And then you have closely following anaplasmosis and spotted fever rickettsiosis, which include Rocky Mountain spotted fever, maculatum fever, etc. And then the rest of the graph, you see the other ones like ehrlichiosis, Powassan virus, etc. They're less frequent. The graph on the right, what we can see is the distribution according to months of the year. And all of these infections have a summer predilection. So in the summer is when these ticks, people go outside, they have more contact with the nature, and the ticks are in nature, and they have more risk of getting infected. The other thing, it pans out across all the different infections. They're more frequent in the summer. So in the summer, the first clue I'm going to give you is, if anybody presents to your clinic with a flu-like illness in the summer, a tick-borne illness has to be in your differential. Doesn't mean it's going to be a tick-borne illness. It could be any other type of infection, but you cannot take that out of your differential diagnosis. And depending where you live is what types of infections you have to think about. For example, if you're living in New Mexico, the only 2-3 tick-borne illnesses that you can acquire in the state of New Mexico are tularemia, hypothetically Colorado tick fever, which is a viral infection, and Rocky Mountain spotted fever. You cannot acquire Lyme disease in New Mexico. Now, if someone has traveled to a place where Lyme disease is for vacation and comes back to New Mexico, of course, they can have Lyme disease, or they can have Babesia or ehrlichiosis, depending on where they have traveled. So history here is critical. When you're seeing a patient with a flu-like illness in the summer and a tick-borne illness is in your differential, you need to ask them, where have you been in the last few weeks, and what have you been doing? And you're not getting nosy. You're just a provider trying to find a cause for their flu-like syndrome. So this is the distribution of Lyme disease in the United States. Each dot represents one reported case. And you can see that the northeastern United States is the most heavily affected areas. Now, you may see also in the Pacific area, because you have the Pacific tick in that area. Now, all the dots that you see in the middle are probably people who travel to these places, but the dots reflect where the residence of that person is. So if you live in Texas, but you went to California for a vacation and got bitten by a black-legged tick there and got Lyme, you come back to Texas, this is going to be reported as Texas, not as California. So you can see that the brown dog tick is distributed all over the United States. Nevertheless, it does not cause Lyme disease. So the distribution of a tick does not necessarily match the disease that is happening. So as I mentioned, black-legged ticks are the only ones in the US that can transmit Borrelia. cause Lyme disease. So ticks pick a place to wait by identifying well-used paths of animals or people. Then they wait for the host to come. They rest on the tip of the grasses and shrubs. And as I mentioned, they cannot fly or jump, but they wait in a position known as questing, and I'll show you a photograph of that. And then they just attach to the host that's passing by and grabs them. So how do they find the host? They can sense odors, they can sense breath, they can sense moisture, heat, vibrations, and even shadows. And then that's why they will go to that shrub that is close to where all these things are happening. So you can see here a tick that is on the tip of a shrub with their 6 legs attached to the shrub, getting stability. And when this animal with this hair passes by with the 2 front legs, it'll grab that hair and then ride with the animal wherever that animal is going. It's basically waiting for you. I mean, they're stalking, they're stalkers. They just wait for you and then boom, just grab you when you touch them. So when the tick bites you, it usually generates this little inflammatory response, but people do not feel it because the tick, first, when it goes through the skin with the hypostome, which is like the little peak or sword, it secretes a cement around that hypostome that makes it difficult for you to pull that tick. And if anybody has ever pulled a tick, you know it's not that easy. I mean, they're kind of refusing to get out of your skin. And then what they do, they inject blood thinners so they can suck up the blood and it won't clot. And also immune suppressive agents, basically anti-complement activity. So the bugs that they're going to inject into your blood can survive that immediate introduction into your blood system and survive. Now, the important thing is that you can see it here in this little green little dots. It would be like the Borrelia. The Borrelia is on the gut of the tick. And it has to travel to the salivary glands. Let me show it here first. So the Borrelia has to go to the salivary glands for it to be injected into the host. But for that, it needs to be activated. What activates that Borrelia is probably when the tick starts drinking blood, that the temperature of the blood, the pH of the blood, and other proteins trigger some genes of the Borrelia to change and make them able to migrate to the salivary gland of that tick. And that's called tick activation. Now, except for Powassan virus, all the other tick-borne illnesses survive in the tick's gut, and they will only travel to the salivary gland once the tick has bitten you and is ready to inject saliva and feed. So why is this important? Because the reactivation time it's different among the different pathogens. For a Borrelia to activate, meaning they're in the tick's gut and they want to migrate to the tick's salivary gland, it takes 24 to 48 hours. So that's the time that you have to pull that tick out of your body before it can even infect you. And that's why when you go camping or when you're outdoors or around your house, check, and you know that there are ticks in your environment, you need to check your skin every day, because if you're able to pull any ticks out that day, they probably will not have caused any infection. Now, there are some other ones that are a little bit more trickier, like tularemia, Powassan virus, and Rocky Mountain spotted fever, rickettsia. They have really low times before they activate. Like tularemia, in 15 minutes, it's ready to go. That's going to be a difficult one to avoid just by pulling your tick out. Okay, so going back to the initial question, which of the following are true? And they were all true. Ticks choose environment over their host to survive. Ticks do not need pathogens to survive. The pathogen needs the tick. Pathogens are transmitted from tick to host through the tick's saliva. And most pathogens, except for Powassan virus, live in the tick's gut. I think this is just for your general knowledge. You're not going to save anybody's life with this information, but I thought it was interesting. Okay, so if you are ready to take your nap, or to multitask and watch something else. If you learn this slide, that's all you need to know. And then you can do whatever you need to do. And I'll wake you up at the end of my presentation. So Lyme disease is the most common vector-borne disease in the United States. It's caused mainly by Borrelia burgdorferi and rarely by Borrelia mayonii. It is transmitted to humans by the bite of an infected black-leg tick. So the typical symptoms include just general, like a flu-like illness in the summer, fever, headache, fatigue, and a rash. That's very typical, and that's what you need to learn how it looks like. But for that, you will not be able to multitask or take a nap. You're gonna have to stay awake, or you won't see the rash. If left untreated, it can spread to joints, your heart, and your nervous system, and that's called disseminated Lyme. And the diagnosis of Lyme is based in the first stages is clinical. It's like finding a typical rash or erythema migrans, and also with a history of exposure to infected ticks. And laboratory testing is helpful if used correctly sometimes. So you not always need laboratory testing. In a patient who had a tick bite by a black-leg tick, or something similar, or they look like one, and they have symptoms with a typical rash, that's it. And you're in the right area of the country, that's Lyme disease, you treat it. Most cases of Lyme disease, I'm sorry, there's a misspelling here, but most cases of Lyme disease can be treated successfully with a few weeks of antibiotics, and the patients will never have any other problems. But if you treat it early, you're probably going to be more successful. And prevention includes insect repellent, removing ticks promptly, applying pesticides, reducing the tick habitat. And for Lyme disease, which is not here in this slide, also there is a role for post-exposure prophylaxis with doxycycline. We'll talk about that in our last slide. Okay, you can go to your nap and you can, or multitask, and I'll bring you back in a few. So this is we went over this. This is the geographic distribution of Lyme disease. It is transmitted by the black-leg tick. And here are the list. I'm not going to read them all the states in which there's high incidence of Lyme disease. So if you live in any of these states, beware if you get bitten by a tick, and if it's a black-leg tick, you're at risk of acquiring Lyme. But the geographic area is expanding to neighboring states, and this is basically due to climate change. So there's 3 stages for Lyme disease: the early localized stage, the early disseminated stage, and the late Lyme stage. The early localized stage, which is ideal to make a diagnosis there because you treat the patient, it won't have any problems. It has the characteristic skin lesion called erythema migrans. The patient may or may not have constitutional symptoms. So not everybody comes with that summer flu. Someone may come and consult you because of the typical rash they're having. If the patient is not treated, this will evolve quickly in a couple of weeks to disseminated early Lyme disease, in which the erythema migrans rash changes a little bit. The lesions become multiple and a little bit different than the original one. And the patient may have heart issues or neurologic findings. And in a few cases, the patient may present with these cardiac or neurologic findings. Cardiac could be a heart block or myocarditis, and without a history of ever having that early rash. Now that could have happened because they missed the rash, they didn't notice it, or it could have happened because the rash wasn't there, which is rare, but it could happen. And then if the patient is not treated within these 2 first phases, they can develop late Lyme disease, which is intermittent or persistent arthritis involving one or a few large joints, or mild encephalopathy or inflammation of your nerves or polyneuropathy. This may happen months to a few years after the initial infection, and sometimes arthritis may be the first manifestation of Lyme disease that the patient has if they don't recollect having any of the other previous stages. So incubation period is 3 to 30 days. And that's important because if you live in an area where there's no Lyme disease and someone shows up and they think they have Lyme for whatever reason, usually because they've been Googling and found a webpage that says that everybody in the US has Lyme, and they travel to a Lyme area, and you're seeing them, let's say, for a rash, but they traveled 2 months ago, then that rash is not due to, at least not to early Lyme disease. The erythema migrans is a red annular rash. I'll show you some pictures that expands gradually over days to becomes more than 5 centimeters in diameter. And this number 5 is not put there randomly, because remember, tick bites can cause a little rash around the tick bite, but that rash is usually less than 5 centimeters. That's why it's important to look at the size of the rash. And the typical one has central clearing and looks like a target lesion or a bullseye. And it occurs in 70 or 80% of infected persons. And then they can come with that flu-like syndrome, and there could be lymphadenopathy. So these are photographs obtained from the CDC website. This would be your typical annular bullseye rash. See the erythema with the central clearance. Now this one is a lesion that is expanding a little bit. This might be, an early dissemination. This one, you can still see the central clearing, but it's bluish. It's not so red. And this one has a nodule in the middle. So there's variations of it. And if you see this one, it's probably going to think about Lyme. But if you see this one, you may not think about Lyme. And in people with dark skin, it might be a little bit more difficult to detect them and interpret them. And this is the one where this is early dissemination of Lyme. So the patient may have had a bullseye, but now it's spreading. This is another manifestation. And this is a purple lesion on someone with dark skin in their knee. Now, this is not Lyme. When this erythema that occurs around the tick bite and it's less than 5 centimeters and goes away quickly, and it's not Lyme disease. And this one here, this is a tougher one to diagnose. This is southern tick-associated rash illness. And it occurs mainly in the southern states, but the tick that transmitted, which is the Lone Star tick, can be seen up as north as Maine, where you do have Lyme disease. If you live in the southern states and the patient has not traveled, you can say this is not Lyme, this is Starry, and be over with. If the patient lives in the northern part, that's going to be a difficult one to differentiate. And you probably ended up treating them like Lyme disease. Okay, dissemination. 60% of patients who have not been treated will progress and disseminate the disease. Most manifestations will appear in the next few weeks or months, and they're usually either rheumatological or cardiac. And like I mentioned, some people do not have any history of having the first lesion in the beginning, but the majority do. 80% will have that first erythema migrans lesion. So the late dissemination may present with multiple rashes. These are all the neurologic symptoms. They can come with Bell's palsy or facial nerve palsy or aseptic meningitis or inflammation of their nerves expressed as radiculoneuritis or multiple nerves involving different parts of your body. Sometimes it's very painful, and very rarely patients can have like central nervous system symptoms like cerebellar ataxia, meaning you can't walk well because you lose your balance, encephalomyelitis, or intracranial hypertension. These are rare. The classic triad is a cranial nerve palsy, like Bell's palsy or facial paralysis, aseptic meningitis, and some nerve pain in your body. The cardiac manifestations, usually it's either a heart block or a myocarditis, and that can present as chest pain or can present as shortness of breath, depending on how bad the disease is. And then the rheumatological manifestations, these are usually inflammation of your joints, large joints. The knee is frequently affected, and they can also be accompanied by pain in your tendons and in your muscles. Now, I briefly want to mention this post-treatment Lyme disease syndrome. In 2006, the American Infectious Disease Society of America proposed a definition because I don't know if you have experience, there's a lot of people that think they have chronic Lyme. And chronic Lyme has really not been defined as an entity, but this is kind of a middle ground in which the IDSA came up with a definition. So you have to have a history of Lyme disease that was properly treated, that your symptoms resolved, that your objective symptoms resolved, meaning if you had the erythema migrans, it went away, you had arthritis, it went away. But the patient, despite the fact that they were treated properly, they persist with symptoms that could be fatigue or muscle pain, cognitive, very similar to post-COVID. But those symptoms have to occur with 6 months of the diagnosis of Lyme disease. They can come and go, but they can be permanent after completing proper therapy. Anything that doesn't fall into this will not be post-treatment Lyme disease syndrome. So the diagnosis, you have your general labs, you can have a elevation of your SET grade, you can have an elevation of your liver enzymes, it's not very common, and mild elevation of your, or decrease in your renal function, but that's not very common. In areas where Lyme disease is common, it should be diagnosed clinically, and you do not need to order Lyme serology. Easier said than done because everybody orders it, but you don't really have to. And if the patient does not have that, early disease with a typical lesion, and they present with carditis or rheumatological conditions, or a rash that's not very typical and it's extending, then that's where lab work will happen. So there's two different. The CDC came with two different propositions on how to test for Lyme. So the first test is an IgM, IgG immunoassay. It's an ELISA basically. And if it's negative, you're done. The patient doesn't have Lyme. If it's positive or equivocal, then you can do a Western blot. And this could be an IgM or an IgG Western blot. If the patient's symptoms have been for less than 30 days, you do both, IgM and IgG. If the patient's symptoms have been more than 30 days, then you just do the IgG blot. And then you have to have 2 bands for this to be positive, consider it to be Lyme disease for IgM, and 5 bands that are positive for IgG. The other option, which is the modified 2-tier testing, the same part is the same. You do the same immunoassay, positive or negative. But if it's positive, instead of doing an immunoblot, you do another immunoassay, which is a different one. It targets different antigens. And if that one's positive, then the patient has Lyme. And if it's negative, it doesn't. And the same concept applies. If the patient's been, the first test is positive, the patient's been symptomatic for less than 30 days, you do an IgG and an IgM immunoassay. But if the patient has been symptomatic for more than 30 days, you do only the IgG immunoassay. I'll stop there for a second, see if there's any questions, because there's a lot of questions on testing. I'm happy to answer them if anybody has any question. No, if not, I'll go on. So treatment, the treatments differ depending on the stage of the disease. The important is that you need to treat these patients early. When they have the classical erythema migrans rash, you do not need to do any lab testing, just treat them. And you have either doxycycline for adults or amoxicillin. Doxycycline is preferred. Amoxicillin you may use, for example, if it's a pregnant female. And depending on the severity, it could be a child. Now you have cefuroxime also as another option. If the patient's allergic to amoxicillin or to doxycycline. And in children, again, you have the same options. It's just that the doses will vary. And you can see that the treatments are all 10 to 14 days or 14 days, depending on the drug you use. So it's basically a 2-week antibiotic treatment. I'm not going to go over the details of the dosing over the other presentations of Lyme, just letting you know that there are specific recommendations. If you have a facial palsy, it's still doxycycline, but the treatment duration is a little bit longer. If it's Lyme meningitis or radiculitis, you have the option of IV ceftriaxone. Again, the treatment is a little bit longer. And if you have heart problems, like first-degree AV block, or a severe, more severe disease, a Navy block that may go to a 3rd-degree block or a 3rd-degree block, then the treatment there is IV if it's severe. If it's the first one, you have basically a lot of oral options to treat these patients with. And doxycycline, I think doxycycline is a wonderful drug. Whoever invented it should have gotten the Nobel Prize. We use it to treat tick-borne illnesses. We use it to treat malaria. We can use it for MRSA. We can use it for atypical organisms. It's like a drug that has no limits, basically, except for COVID. It doesn't work for COVID. You're still thinking it may work, but it does work for many other things. And then for arthritis, again, this is a lookup thing. The only thing you need to remember is that depending on what type of Lyme presentation you have, I'm going to have to look up the doses and the type of drugs that you have. But unless you're a child or pregnant, doxycycline is the way to go. But even in children, you can use doxycycline. So the teeth staining that has been blamed for tetracyclines was actually for tetracyclines. So doxycyclines in short amounts of time usually will not produce that. But if you're concerned, here you have some other options. And to finalize, if you're in one of those Lyme states and you have tick bite, there is a role here for post-exposure prophylaxis with 1 dose of doxycycline, 200 milligrams, as long as you're not pregnant. No, let me mention this. It doesn't mean it won't work for pregnancy, and it doesn't mean it's very risky for pregnancy, but it's not recommended as easily as for non-pregnant females. You have to have certain criteria, and you need to meet all of these criteria. They include attached tick identified as an adult or nymphal deer tick or the blackleg tick. So you have to have someone that has paid attention to the first few slides of this lecture and know what these ticks look like. The tick is estimated to have been attached for more than 36 hours by the degree of engorgement or time of exposure. If the belly of the tick is full, they probably have been there for a while. You have to get prophylaxis within 72 hours of tick removal. And the bite has occurred in a highly endemic area for Lyme, and doxycycline is not contraindicated. If you meet all of these criteria, you can give the patient or the child a 1 dose of doxycycline, 200 milligrams for an adult and 4.4 mg per kg for a child. And that will reduce the risk of Lyme disease. This does not apply for any of the other tick-borne illnesses. It is not recommended. As a matter of fact, it's contraindicated to use it in the other tick-borne illnesses. And I'll stop there. And if you fell asleep, you can wake up now. And if you are awake, you can ask questions if you want to.
Thank you, Dr. Mayer, for a great presentation. I know I'm disgusted with ticks, so I don't know if anyone else is, but yuck. Do we have any questions for Dr. Mayer over Lyme disease at this time or tick-borne illnesses? Dr. Brown?
So the black-legged tick and the deer tick are 2 different names for the same tick. They're both Ioxides scapularis. Is that right?
Yeah, so the one in the northeastern part of the United States, yes. The other one is the one in the Pacific coast has a different name. Is a Ioxides, I think it's Pacificus.
Pacificus.
I'm not mistaken. But it is basically the same blackleg the blackleg tick.
Pete, I don't know if you can hear me or not, but do you see a lot of Lyme disease in your area?
Are you asking me or someone else?
No, asking Pete Francis.
Oh,
He may not be on.
Sorry. Yeah, I'm here. I do, but
You
I think oftentimes the concern, the question is, that we get is how long has it been attached? And everyone identifies it as a deer tick versus a dog tick or something to that nature. I have not seen very many bullseye indicators or rashes related to tick-borne illness since I've been there. But I do have patients that have had acquired Lyme disease and have been treated in the past. Or we do have people that have all these inflammatory disorders or conditions that we try to do a rule out for that for possible, carrier of Lyme disease. So it's interesting because we just traveled to Florida and my wife and I just put a garden in, and we get to Florida and lo and behold, she has a tick attached to her elbow. And I'm like, wow, what are the chances? Did remove it. Again, it wasn't like suspicious. I didn't really think it was engorged very much. But of course, she was freaking out. So she did get treated just prophylactically, just locally down there in Florida. But so we're waiting on the all the other symptoms that could possibly emerge, but nothing's happened. I said, quit looking at it.
Thank you, Pete.
Yeah. Thank you.
Mary, you said you see a lot of it in New York at St. Regis. That's interesting.
Had quite a few interesting cases there develop over the last few years. I think my most memorable one was elderly gentleman there and this was probably about March or April. He had been just stacking wood, cutting wood, and then turned out that, he came in, did not even realize he had a tick bite until we had seen him like once or twice, because blood pressure was high, pulse rate was low, and we checked it. He did end up with like the AV block. I can't remember if it was 1st degree or 3rd degree, but he ended up like, hey, I have a bump on my arm. Sure enough, we look at it and there's this, tick that's completely embedded, like crusted right around, like it was stuck. So as soon as we took that out, told him to go to the hospital. So sure enough, he had Lyme disease. So yeah, he did not want to go any of those initial visits. They were hoping that he would pass out so we could send him via ambulance, but it didn't happen. So, but he's doing fine now.
Good, great. Have any other questions or comments? There is the link to the continuing education credits survey. If you will click on that and fill out the survey and get your CE credits. I don't have anything else. It is 11:59.
There's one question, Brian, there that is asking if AV block occurs, does it resolve with or without treatment? So you need to treat them, the antibiotics, usually ceftriaxone. I don't have at the top of my head if there's any percentage that will resolve spontaneously. What you don't need many times is a pacemaker. So you have to, that's the important thing, because if you see anybody with a 3rd degree AV block, they'll need a pacemaker. But if it's related to Lyme and you have it monitored, you can try treating them and see if that reverts before you put a definite pacemaker. You can transiently pace them if they need to.
Please join us next month. We will be discussing all hepatitis viruses, since it is Hepatitis Awareness Month. We have Dr. Cody Chastain from Vanderbilt University who will be presenting on that. So join us next month, July 14th, I believe. Yeah, 2nd Friday of every month. And we will see you then. Thank you all. Bye.
Bye. Thank you.